Hello everyone, nice to see so many of you joining us today. I'm Lisa Newble, one of the senior clinical consultants that works for the National CLEAR programme here at 33N and predominantly work on the CLEARnotes programme. I'm going to be hosting today's webinar, which is the second in our three-part Beyond Pilot series, which explores the learning from our live AVT deployments across the NHS. We will be discussing how organisations can move beyond pilots to achieve scaled, sustainable adoption that drives productivity and enhances patient care. So a bit more about today's... Oh, bit of an echo there. Somebody not on mute. There we go. A bit more about today's session. As we all know, AVT promises significant productivity gains, which helps our clinicians save time, reduce their admin burden, and help them to focus more on patient care. But what's equally important is recognising that true and sustained productivity can only be achieved when safety, assurance, and clinical integrity are built in from the very start. So in this session, we're going to be looking at how NHS sites are embedding safety and compliance into their AVT adoption, drawing on our real-world learnings from live deployments, and looking at the practical steps to take to make sure that technology supports rather than disrupts clinical workflows, and how that foundation of trust is essential for scaling these. We'll also be introducing CLEARvalidate, which is a multi-layered assurance framework that combines data analysis, semantic review, and clinical validation. And this proactive approach identifies and mitigates the potential risks early, ensuring that AVT is not only efficient, but also safe and compliant. I just want to remind everybody, I know it's in the chat, but just that the webinar is being recorded so that we can share it afterwards on our website and across our networks. So just so you're aware. Next slide, please, Namisha. We're going to take a quick look at who's going to be speaking today at the webinar. I myself will be one of your speakers. Amrit Semi, one of the Advanced Specialist Orthoptist and Digital Development Manager at Moorfields Eye Hospital. We have Dr. John Jeans, who's an NHS consultant anaesthetist and the national lead for the CLEAR programme and CEO for us here at 33N. And Dr. Ken Ting, who is also an NHS consultant anaesthetist and head of clinical informatics at 33N. So let's take a quick look at our agenda for today before we get started. John's going to kick off the session with a talk on the importance of ensuring safety and compliance in AVT adoption and its role in driving those sustainable gains. I'll then go on to discuss the key elements of clinical performance through structured quality assurance and monitoring, drawing on our own experiences of deploying CLEARnotes across multiple sites. Amrit will then share the safety first approach and deployment experiences of AVT at Moorfields Eye Hospital. And then finally, we'll hear from Ken, who will explore the example of AVT validation framework that is CLEARvalidate. We'll wrap up with a discussion going through some of the points made during the presentations, and that will also be your opportunity to share your insights and ask any questions you may have to our speakers. If you do have questions and you don't want to forget them, you can just pop them in the chat or just raise a virtual hand during the Q&A session at the end. That is now all from me at the moment, and I'm going to hand over to John to start the session.
Thank you very much, everyone, and thank you very much, Lisa. I'll just give everyone a brief overview of the importance of ensuring safety and compliance to drive sustainable gains. And I think this is something that is absolutely critical as this technology starts to become used more widely across the NHS. So if we can move on to the next slide, please. So Before we go into the details of that in too much detail, just as an overview, to just state what AVT is. So AVT is a technology that listens to clinician-patient interactions and generates medical records and letters. As we all know, the purpose is to reduce manual documentation and boost productivity. And we've seen there's many examples now from small-scale pilots of significant productivity gains. And this obviously therefore fits with the NHS 10-year plan and the recent guidance that's been released nationally in this area. But safe adoption is absolutely key, and the compliance, governance, and safety elements that we'll talk to today are foundational for that. It's also important to state that there will be a lot more guidance and detail coming from nationally from NHSE over the coming days and weeks, and the purpose of this webinar is to add to that and give some tangible real-world examples of how how to think about operationalizing some of the safety and compliance features here. Move on to the next slide, please. This is self-evident, but it is worth just stating. Patient records are safety critical. They're a medical legal document, and anything that is AI generated must meet the same standards that we hold when we are doing our own clinical documentation, be it if your trust is handwritten, to be it if your trust has a fully a full whole service EPR. And so the standards that we use when we use an AI tool for documentation need to be of the highest standards, because our public professional trust from patients and from colleagues will hinge on this. So it's important that we get this right from day one. Move on to the next slide, please. Some of these studies are a little bit out of date, but there has been a lot. There is a burgeoning area of research in this area, and what we know is that if this technology is not deployed well, there can be a high level of factual and contextual inaccuracies within any documentation. And not only is that a risk from a patient safety and experience perspective, but also it's a bit of a waste of time, because you sit there, you generate a note, then you have to go back and redo the entire thing anyway. So it's important that there is that there is a certain level of quality in any of the outputs. It's also important to state that lots of minor inaccuracies, if they are held in a patient record, can generate significant accuracies and generate a documentation debt over time. And so as we start to use this technology more broadly across the NHS, we need to have a systematic way of delivering assurance. It's not about just the odd manual spot check or faith in a claim that's made here or there. We can move on to the next slide, please. And to that point, AVT isn't a drag and drop solution. It is a very flexible tool that can be used very quickly, but as this technology is scaled across thousands of staff with an organization, or across the NHS for hundreds of thousands of staff over the coming months and years, the level of customization and the level of governance and assurance we need to put into it is going to be high, so that we can get good quality outcomes and develop high quality data from the use of this kind of technology. So ensuring data security and appropriate information governance is absolutely fundamental here. I was speaking recently with the person who authored DTAC 5 years ago, and it's a very good document. It stood the test of time, and it's actually a very important one for use with AI, and it should be completed, in a standardized and robust manner across different parts of the system. 129s and 160s are also very important. Something as well that I think is key is gaining meaningful patient consent. This isn't just through information leaflets within a clinical setting, but also from colleagues having the conversations with patient prior to using this kind of technology. I think it's really, really important. And going back to that, holding professional and public trust, that's a very, very important thing. And the safe adoption of this tech very much hinges upon having co-designing the way that it is deployed, I would say at a service by service level, especially across large organizations. So if we move on to the next slide, please. So how do we do this? For me, this is about an approach and it's about a way of working. We have to have safety, compliance, and appropriate governance in our thinking right from the start of using this technology. So that is about the way that we approach using this technology. We've got to embed governance from the start and ensure that we are thinking about not just the documentation, but following the spirit of the documentation, not just having the letter. There's a co-designing of the tools so that they are customized to individual members, individual staff groups, and individual services. And that's very important, having standardized and consistent outputs. Post-deployment monitoring, the centre has suggested appropriately that MHRA1 classification should be attained by all providers of this technology. And part of that is having continuous monitoring and evaluation, and that's key. And that conversation should be had right at the very start of using this technology. And engaging in feedback loops from all stakeholders is absolutely key. So many updates and changes can be made in a consistent and cogent manner. If we move on to the next slide, please. Going back to the point about there's different documentation that needs to be done. The documentation is the documentation, but it's about the spirit of the documentation and doing that with the patient and the public's best interests at heart, and also bringing people on the journey. And that is therefore engagement is key from the start. The co-design of how these AVT solutions are deployed is critical. Clinical involvement and leadership within organizations, and not just with clinical, but with administrative and operational colleagues, is very important. This isn't just about training, it's about helping staff get the most from the tools and explaining what the technology can do, understanding workflows and appropriately changing and transforming those as people become more aware and comfortable with the technology. And if we do that well, colleagues will become advocates. And if the colleagues become advocates in an appropriate manner, the impacts are profound. And so therefore, building feedback loops and early champions is absolutely key. All of this stuff is stuff that we know, but doing it consistently across the NHS is tricky. And it's about, I think, everyone who's on this call having the foresight and thinking to be able to do this, have this approach consistently in the deployment, not just of AVT, but of all this transformative AI technology that we're going to start using over the coming months and years. Move on to the next slide, please. This, again, when I was sort of reading through and talking to these slides, the stuff here is all self-evident, but it cannot be overstated the importance of multidisciplinary engagement to get the outcomes that we want. And that involves both clinical and operational teams. So that's frontline users, clinical safety officers, service managers, administrative colleagues. It's all absolutely key. Digital teams hold a wealth of knowledge about what works well and what doesn't work well within their organizations, and themselves, IG colleagues and data protection officers need to be engaged from the start. Obviously, any suppliers of this technology need to be part of the conversation because it is a holistic solution. And there needs to be strong consideration for external assurance partners, so that we have validated results for any outcomes that are achieved. It's very important to consider wider organizational stakeholders. So there's education teams within organizations that can be very supportive, as well as transformation teams and patient and public representatives. So it's actually a large group of key people that need to be involved. But when colleagues are involved early, when things are done in a collegial and supportive manner, even though you may go a little bit slower at the start, the pace at which you can then generate further benefits is actually quite profound, and that's really important. We move on to the next slide, please. Final thought from myself is that governance and safety breeds confidence, and we will need a lot of confidence to use this technology well at scale. And as I said, if we do this well from the start, it accelerates the adoption. And I think it's, although it may feel a little bit slower for potentially a couple of weeks or maybe a month or two, it allows us to do things well going forward and allows colleagues from a lot of different backgrounds to engage with it well and trust the integrity of the technology, and also knowing where there's gaps and where things need to be improved. And all of this combined leads to high impact and sustainable productivity gains. And that's something that we know that we need for our patients, given the funding constraints that we have at the NHS more broadly. So I think that is my last slide, and I'll hand back to Lisa and say thank you very much, everyone, for your time, and look forward to hearing some questions at the end.
Thanks, John. So I am going to just take us briefly through how we monitor performance through our structured QA, sort of quality assurance and monitoring. Next slide, please. So what is quality assurance, and why is it so important when we're deploying our AVT solutions into clinical environments? So as John alluded to earlier, in healthcare, every word matters. So therefore, a single transcription error or omission can change the meaning of a clinical note and potentially affect that patient's care. So that's why AVT tools must meet the same standards of reliability, safety, and accountability as any other clinical system that you would use with your patients. So it's quality assurance that protects both the patient and also the clinician from risk, making sure that the outputs are accurate, they're consistent, but also clinically appropriate as well. This not only helps to build trust in the technology, but it also helps how we monitor and validate it, and then go on to improve that over time. So when our clinicians can see that the process is transparent and that it's data backed, then they're far more confident in using these tools as part of their daily practice. So today, I'll just be giving you an example of the QA process that we've developed. These obviously may very slightly vary for different AVT providers, but it's more about the importance that these processes should be in place. Next slide, please. So the process that we designed for CLEARnotes is a framework that has been designed with that particular principle in mind, that we have a rigorous multi-stage assurance process that's tailored specifically for those NHS or health settings, with that governance, transparency, but more importantly, that continuous improvement built in right from the start. So over the next few slides, I'm going to take you through each stage of that process, from that pre-launch testing to go live validation, and then finally onto that continuous monitoring and evaluation. So let's have a look at how we put that into practice. Next slide, please. So stage one is what we call our pre-launch phase, which is also known as the negative assurance phase. And the aim here is to make sure that the tool is completely safe, that it's stable and consistent, and that it's free from hallucinations before being introduced into a live clinical setting. We would normally start by going to site, doing a site visit, meeting with the services and the clinical leads, mapping their pathways and taking a look at their workflow to understand exactly how the AVT will integrate into their existing practice, and if there are any sort of barriers to overcome before we get started. We also make sure that they've got the adequate hardware, so thinking about your microphones, and that their software allows access to the tool to make sure that it will run smoothly in their systems. What is really important to do at this stage as well is conducting what we would call an in situ mock consultation, which is essentially just a realistic sort of practice-based consultation with that clinician that allows us to see how the first draft of that prompt is performing in their genuine working conditions. This will be the first time it's actually tested in as real a setting as possible. What we will have had before is some what we call prompt setup sessions, where we work with that clinical lead to make sure that the templates are as reflective of their current practices as possible. And that then assures that everything aligns with what is already established as their clinical process. So thinking about those things there and about our prompts, it's the prompts that we're really wanting to quality assure. So a real key part of this stage then is our control consultations. So what we have is a bank of audio files, and we have some that are non-medical and medical but non-specialty audio recordings. And these are designed to test the system's reliability and make sure that it doesn't produce any fabricated or irrelevant responses. This then gives us that assurance against the hallucinations that I was talking about earlier. It also allows us, if you do an in situ mock consultation, it means that you can conduct a sound tolerance test to make sure that the tool can handle the background noise within that setting, as well as any diverse accents they may have within the team. And we validate these against our in situ consultations to confirm that accuracy and realism. And then finally, what we're doing is checking that the template is accurate, and that the outputs that are coming from those consultations and those mock consultations are following that clinical structure and the way that they want their output to be given. So that everything's coming under the correct headers, etc. So overall, stage 1 provides the assurance to us that the tool is technically robust, that it's clinically appropriate, and then ready to move into the next phase of live deployment. Next slide, please. Stage 2 then is our go live phase. And this is where the tool transitions from the control testing into real world use. And what our aim here is to validate the performance with real patients and the clinicians within their clinics. This then helps us confirm that the tool is functioning safely, accurately, and reliably in the genuine clinical environment. And this is where you really start to see that sort of refinement process, because it's only at this point that you can see really how it's handling those real live consultations within that particular service. So what we would normally do is begin with what we call a soft launch, and that's usually just involving a small group of users over a couple of weeks, and that controlled level of rollout allows us to see it in live interactions and gather feedback while sort of minimizing any operational risk or any risk to patients. And during that 2 weeks, we run what we call rapid feedback cycles. So that allows us to refine the prompt and make any iterative updates so that we're sort of continuously updating the prompt to make sure that it gives us nice, reliable outputs, but also that the clinicians are getting the outputs that they want and need. And it's often not until this stage that they really know what they want. So quite a key phase in all of this. That sort of continuous iteration based on their feedback is really, really key. We also, as part of that feedback loop, monitor and categorize any errors that may occur, and we sort of measure these against quite strict thresholds. So we've got our minor errors and our major errors. So for our minor errors, ideally we would want this to be below 5%, and these refer to sort of smaller inaccuracies that we sort of assess wouldn't affect clinical safety. So for example, if a patient's name wasn't quite spelled correctly, or there was an omission of a minor detail that wouldn't necessarily have any clinical significance on the patient's care. Whereas our major errors, we would want to be less than 1% of consultations. And these are the ones that we would class as potentially clinically significant. So it may have clinical implications on the patient's care. And these can be things like hallucinations or omissions of significant information that would affect the patient's ongoing care. So an incorrect diagnosis, incorrect or inaccurate medical history, incorrect allergies or incorrect medication, things like that. So every iteration then is validated with the relevant specialty and sort of within that specific use case to make sure that the performance improvements are sound and clinically appropriate to sort of move forward and roll out further across the wider team. So therefore, stage 2 is ultimately about that intensive refinement, but doing it in a really controlled way and using that live feedback to strengthen the accuracy, and making sure that the tool is performing safely and consistently within that real world setting. Next slide, please. Then finally, stage 3 is what I would consider to be just as important as your initial quality assurance, if not more so. And that's our continuous monitoring and evaluation phase. So it's a real sort of critical part of that ongoing quality assurance. So while the earlier stages focus on making sure the tool is safe and effective before it goes live and during rollout, this phase is about maintaining that safety and accuracy and building that trust with your clinicians. So our objective is to make sure that the tool continues to perform reliably in live use. So we're not just dumping and running. We are sort of focusing on that support during go live, but then every day thereafter as well. So building in that the process to make sure that that's possible. To achieve that, we have built several ongoing activities, and these include real-time monitoring of key metrics, such as those error rates that I discussed earlier. We also look at system performance as well, so looking at uptime, response speed, and carrying out those quarterly quality assurance reviews. So we will send regular reports to site with all of these metrics and evaluate those to see if we can identify any potential emerging risks or performance trends. So that user feedback is just as critical in this stage as it is in that go live stage. So that sort of remains at the core of that feedback loop, allowing those clinicians to be able to share their experiences with us directly so that we can make improvements as we go through and do them as promptly as possible. So that continuous tracking of errors and resolution just makes sure that even the smallest of issue is detected early and addressed as soon as possible. So the key components of this particular stage make sure that we have that sustained accuracy and reliability, and we do actually see that there's a bit of a curve, and it comes into what I call the stable phase, where there's a lot more of the thumbs up positive feedback and less of the your issues coming through, which is nice to see, and you do really see that in the data, which is nice. We do continue to refine through the iterative updates, but our clinicians can still feed back to us at any time. There's no end to that. We give sort of that continuous support, and that just makes sure that we sort of remain visible and we share the data with the clinicians to be transparent about how their service is going with the use of the AVT in their team. This stage, to me, I think is absolutely vital, and it's what transforms a successful deployment into a sustainable, trusted deployment of your AVT. It's continuous monitoring isn't just a maintenance activity, it's an active quality assurance process that safeguards our patients, but also helps to build that clinician confidence as well, in that the long-term integrity of the tool. Next slide, please. So in summary then, what should a quality assurance process look like when you're deploying AVT into a clinical environment? So firstly, it must be designed specifically for those clinical settings. And that's why, you know, we do that bespoke prompt iteration directly with clinical leads. We don't repurpose it from sort of general AI QA. And that clinical environments have their own workflows, pressures, and patient safety requirements. So the QA process really does need to reflect that reality from the start. And that's why working with those clinicians is key before you even get started. Secondly, it's really important to combine the layers of validation. So you've got your technical validation to make sure that the system performs as it's supposed to. You've got your clinical review to confirm that your outputs are safe and appropriate and relevant to the specialty. And then finally, your semantic analysis to check that the meaning and the context are accurate for every interaction. Finally, the QA framework must be built around the sort of core NHS governance principles of transparency, accountability, and safety. And that means that responsibility for oversight remains defined throughout the entire product life cycle. Ultimately, quality assurance isn't just a single phase, it's a continuous process. And with, you know, aligning with your MHRA medical device, that is one of the real core principles, is that continual improvement. And that goes across all of your international standards as one of the real key factors there. So from design and deployment to long-term monitoring. And by following a structured approach like that, you can make sure that technologies like this can deliver genuine clinical value while maintaining, you know, really high standards of safety and trust. And that is me. And I'm going to hand over now to Amrit.
Thank you, Lisa. So I'm going to talk about, we were given the tool of CLEARnotes to test and trial at Moorfields Eye Hospital. Yeah, next slide, please, Namisha. So this just gives you a bit of an overview of how we started testing the tool. We actually, talking about safety quality assurance, probably didn't have the right start to maybe testing a tool as I personally would have liked to in an ideal situation. We were given funding from NHS England and approached by the 33N team to test and trial CLEARnotes. And so we had a limited time to get going before that funding expired. And actually, probably before we actually tested and trialed the tool, didn't have enough time to look at the current state of the organisation, what we are currently doing in our trust, and how introducing ambient dictation would change that. What we did is I worked with Ken and Lisa and the team to trial it. So at Moorfields, we're an eye hospital. We have lots of different subspecialties of ophthalmology. It is an eye hospital, so very different to an acute trust. And actually, one of the things that I'm going to talk about is the biggest challenges in implementing ambient dictation in an ophthalmology setting compared to maybe in pre-assessment or any other specialty in an acute trust. So we picked 5 different subspecialties in ophthalmology. One was accident emergency, adnexal, ocular. So adnexal is like lumps and bumps on the eye. Ocular oncology, I'm sure everybody knows what that would mean. Uveitis, so inflammation behind the eye that can affect your vision. And VR is vitreoretinal, so the retina is the back of the eye. So a little bit of anatomy as we go along. if the retina comes off, sometimes that can be quite a big impact on your vision. The retina is where you get all your best vision from. So they're very different types of subspecialties, and actually it was a really good way for us to see how it worked in those areas. And the clinicians who signed up to using the tool were for a very, very broad spectrum, from those who are very digitally literate doctors and those who are not so digitally savvy. There were some nurses that also use the tool who work in extended role. So the phase 1 is we did a dummy run between some of those some of the staff, a handful of clinicians who wanted to test and trial the use of it, and looked at within those clinical areas. So like any hospital, clinical areas can be very noisy, and different subspecialties were in different areas, and also a different influx of patients, volume of patients. So the noise element is very different compared to like from ocular oncology, can be quite quiet because it's a very sensitive topic, and the clinical setup is very different compared to A&E. So A&E being very noisy. Then we did a soft launch looking at testing it with about a handful of patients. And then we went live, and we are currently actually still using the tool to the end of the year. Next slide, please. So for those of you who are interested, this is a bit of a kind of the key milestones in the project up until go live. And one of the key things was getting the appropriate sign off for quality assurance. So information governance, and actually information governance sign off can, in my experience, in my digital role, can be very challenging and time consuming, and it takes a long time to get that signed off because there's so many different elements that can crop up and need to be addressed. And actually, one thing I do have to say is, in order to have really good prompt sign off within the NHS, which can be quite complex, having a company where you're working with who know the answers to everything and can really help streamline that process is really, really important. And thanks to the team at 33N, we were able to get that signed off very, very quickly, which everybody was surprised about. Clinical safety review, we had complete sign off from that. So we have our dedicated clinical safety team at Moorfields. And engaging with the clinicians was really, really important. And not only engaging with a handful of clinicians, every clinical area has a different need and requirement, and we were testing it with 5 different subspecialties. So we had to ensure that we had to engage with each team separately in a different way to ensure that the products, when we went live with using ambient dictation, it was to their specific requirements, to ensure that the prompts were correct, ensure that the transcription, when the transcription was produced, that the layout of the letter and the transcription was to the service needs. We also had a bit of a blocker with IT infrastructure, and I think this is one thing to consider as well, where some trusts might have the PCs in the clinical areas might have microphones embedded in them. However, we didn't have that luxury because of the way that we have the setup. And so we had to order and procure specific mics that were of a good enough quality, so had noise cancellation, and that were able to pick up the appropriate information. So that can sometimes be time consuming. So these are all kind of considerations that probably need to be ironed out before going live. Next slide, please. As a trust, we wanted to know what our success factors were. So we wanted to look at whether we could reduce admin time for the clinicians. Clinicians spend a lot of time on writing letters and documentation. And in turn, if we are reducing admin time for the clinician, whether we could increase productivity, so increase the amount of patients seen per clinic. And more importantly as well, not only just productivity, but the qualitative element of it, and the quality of the experience for not only the clinician, but the patient. When you come in as a patient, you want to have the full attention of the clinician. And if you're with, as the world is going with EPRs and digital documentation, we are spending a lot of our time trying to get used to using different systems. We want to ensure that we're not losing that personal touch between the clinician and the patient, and also making sure that the clinician is happy that they're using a system that they are happy with. Next slide. And then we also wanted to, in order to demonstrate the benefits, we had to kind of quantify that by doing some data collection. So I personally went through to some of the clinics and sat with the clinicians, watched them without using the tool, how long it was taking them to see the patient, do their documentation, write their letters, compared to when they were using the tool. And then we also went a step further and thinking beyond just that clinical area and the impact it would have on the medical secretariat. So we have audio typists who do specific typing letters, and also some of the medical secretaries will do that role. So what would be the impact on them? And we have wanted to also look, we have a tool which we can use called ClickSense, which gives you much more high-level data about the number of letters that are being produced, the number of patients that are being seen by clinics. So all of this kind of data collection is really, really important to show the benefits, but also show whether what we're doing is good quality, and also remembering the safety aspect of things as well. Next slide, please. So just for your information, I put on some of our baseline data that we found. So this is without using the tool. So before we were piloting the tool, we have not only doctors and nurses in the hospital, but we have allied health professions. So what my background is, I'm an orthoptist, so we are autonomous practitioners. We see patients, we write our own letters as well. We have optometrists who do a similar thing in terms of we see patients single-handedly and may not need to see a doctor when they come to our clinics. So looking at the time that they were spending on writing their letters, at the end of a clinic, one orthoptist was spending almost 20 minutes on doing their documentation of letters and after the session. And then I looked at per letter per patient, a doctor was spending 4 minutes. That doesn't seem like a very long time, but when we go over to looking at the data that we collected when we were using ClearNotes, you can see the difference in time taken. Next slide, please. And this graph shows, so the darker orange and the blue shows the baseline data, so the time taken without using the ambient dictation tool. And in the lighter blue and orange, you can see that's the time that it was taken for the numbers at the bottom are per patient when using ambient dictation. So you can see a significant reduction when using the ambient dictation tool. So just for an overview, we found an overall reduction of 7.25 minutes of admin time per patient. So that was inputting into the electronic, so OE for those, sorry, I didn't amend that before this webinar. OE is our electronic patient record, so OpenEyes that we currently use to document our consultation. And then, so the 7.25 minutes was a total of documenting onto OpenEyes and writing the letter. Next slide, please. And there you can see in the table what I just discussed. Next slide. So, so yeah, and I think you know, it's what I would like to have done is probably even do much more on analysing the current state in the organisation before doing the pilot. So I've done a lot more of that since we've looked at data collection of the pilot evaluation when using the tool, but looking into more deeply about what we are doing as a trust, so how we can benefit from using ambient dictation. So what current forms are the trust using on dictation? I've just had this conversation on the call earlier that we have over 2,000 clinicians in the trust. We have around about 800 doctors. We are using multiple forms of dictation tools, so that's voice to voice, so, you know, whether that's on a tape or a different product, or voice to text, so you speak to it and it does a transcription of exactly what you said. And some clinicians don't have anything, so they're doing all of their letter writing manually. And only about 300 doctors, 300 out of 800 doctors, have access to a dictation tool. So we've got about 2,000 clinicians who don't have any access to dictation. So it's really important to understand, if you want to implement ambient dictation, I think this is my big take, is what's happening in the trust, and how many letters are each type of clinician producing, the volume of letters. When you're looking at productivity, I think these specific information is really important to work out the productivity when writing like a business case to ask to implement this in your trust. But yeah, moving on. Sorry, just back at that last slide. So when we looked at evaluating evaluating the use of the tool, we did some qualitative. It's always good and good having your data, but also having qualitative information, the feedback from the clinicians, what they felt about the use of it. So we can go to the next slide. So just a bit of overview of what we found from the pilot. We had 52 clinicians sign up using the tool, but actually only 12 clinicians actively used the tool. And I'll talk about this in a bit more detail, because I think this is one of the things that will really knuckle down on the quality assurance, the governance side of things. And I've put a few of the qualitative feedback that we had from the clinicians when the benefits that they found from using the tool. Next slide. I think the first thing to say is, and I mentioned this before, was about ophthalmology. What we found was the consultations can be very different to what you might encounter in a different type of clinical setting. And we use lots of acronyms, and the way that we document our examinations. So you have to draw pictures of the eye. You have to have specific notations of what the patient's seen and what you've seen. So I think that can sometimes be a little bit challenging when adopting ambient dictation. This was one of the things that did come up. So I talked about how we had so many clinicians sign up to using the tool, but only 12 were actively using it. And part of that was that actually they did find it was helpful, but we needed to spend a lot more time before even doing the go live of the pilot to actually work with each subspecialty to ensure that the outputs from the tool were appropriate for that specific service. We have lots of challenges in terms of different doctors want things done in different ways. They want their letters written in different ways. Having that autonomy for them to be able to, for different services to change things depending on the service needs, but also the clinician needs as well. Next slide, please. We did find that it did work. I mean, you know, the 12 clinicians who did use it, we found it did work. But I think the other thing was the different way of working. So I think John mentioned earlier about it's a new way of working. As a clinician, you don't, especially in ophthalmology, because of the acronyms that we're using and what we document is sometimes very different to the way that we talk to the patients in the terminology. We quite often, when we're seeing a patient, you don't sit there examining a patient and say, I've seen X, Y, I've seen, you know, talk about the condition. So being able to adapt the way that you're working, narrate what you're seeing, and there's a large educational element to it. So learning that way of working so that you can get the best outputs from using the tool. And I think we've definitely found, you know, that it's beneficial. And then going forward to implement this trust-wide, there would be a bigger element and a bigger concentration on education and refining the product to individual service needs. I think I've taken up a lot of time, so happy to take any questions.
We'll just move quickly on to Ken's, and then we can have any questions at the end. Also, if people want to pop any questions into the chat, we can go through those at the end too. So thank you very much, Amrit. It's over to Ken.
Thanks, Lisa. I'll hopefully be relatively quick. I'm Ken. Nice to meet everyone. I'm going to talk a little about CLEARvalidate. It's how we try to drive an assurance of validation for AVTs. I think a very quick way of thinking about AI, as we all know, is they're the newest member in the block, newest team member. Obviously, we have a new team member in our teams. We want to understand how to evaluate them effectively. AI scribes should be no different on how we approach this. But to do this effectively, we do need to understand how they work. So very, very basically, it goes through two separate engines, an automated speech recognition engine, which converts speech to text, and a large language model that interprets this text into a summary that we see. Now, ASR engines have been around for decades. You can see from the example that I have here, I am a man being transcribed into the various versions of I am a man, I'm a then, I'm a woman, I'm a nun. Could have very small changes of word error rate and character error rates, some of which might be innocuous typos, some of which might have huge clinical significance. So it's really quite interesting to see what these metrics are currently providing. Now you add the complexity of large language models on top of this, and now it's trying to interpret from incorrect transcripts, and you get a whole new level of complexity in the subjective evaluation of what really now counts as an error, and most importantly, what's the significance of that error. Now, which one? Moving to the next slide, please, Anisha. Thanks. So I think enough to say that this really drives the point home that we need to understand how to evaluate AI scribes effectively. And our ethos has very much been, if we can understand where the errors are at, we can try to fix them appropriately. To that end, here at CLEARnotes, we've developed CLEARvalidate. This is our own internal bespoke approach to understanding how AI scribe outputs can be evaluated. It's a multi-stage methodology which allows us to understand audio clarity, speech confidence, put that together to understand how words are being spoken in a transcript, understand the meaning of the summaries which are being generated, so not just an overlap of words, combining it with a bit of machine learning, humans and clinicians understanding the outputs to then generate the outcome that creates a model for us to start predicting when errors can occur and how can we correct them. So, which I'm moving to the next slide, Misha. So we didn't want this to be just a theoretical framework. We put 1,000 real-world consultations through this. We analyzed over 7 sites worth of information, pulled in over multiple specialities, and broke this down to 21,000 separate chapters. It gave us a lot of useful information from the fact that actually we understood that the majority of issues that were coming through were because of either audio issues or transcription points which needed to be improved. But also it also helped us identify that true hallucination risk, which we all know are the ones that we are terrified of, is actually vanishingly rare at 0.15%. Both of which drove 2 key outcomes for us. Actually, using this CLEARvalidate methodology, we can help the end user at understanding how reliable AI scribes are, but helping them understand where in the output do they need to focus their effort at, and by doing that, help them trust the AI scribe systems. And on a slightly bigger picture, you are now able to understand how well your clinicians are engaging with the tool. How are they being complacent or not complacent, or editing or not editing these tools? How much time are they spent editing it, and what are the significance of those edits? And all of that brings us together with the final point of how do you then address these problems. So we move to the next slide. I'll just glance across 2 last bits here. So you can see here on this slide, it's 2 transcripts that we've had. So one being in a quiet room with 2 very clear speakers. You can see in the top section here, everything is largely all green, whereas in the bottom part is a noisy speech and a noisy background. What you can see quite quickly in that little highlighted blue section, which I put around the blue box there, it's a bit hard, but in the second line, you can see the entire content of it, which is being 160 centimeters for otherwise well. Number one, the transcript doesn't make grammatical sense either. And it goes on to say, if you've had a heart attack and a thick feet, again, it doesn't quite link into a conversation about the doctor having a patient coming in with chest pain. As a clinician, I'm now able to say, right, I can successfully, definitively remove any sections of the thick feet. Not only did I never say that, but I can definitively know that the patient didn't tell me that, and I didn't mishear it either. And it's all because the audio and speech were poor. When you take that and translate that into my summary, I can now focus my efforts at editing sections of the summary which I can trust and parts I don't trust. If you take this out and do this repeatedly over thousands of reviews, let me show you, moving to the next slide, please. What you get here is a system level understanding. You're now able to understand how engaged your team are at using this AI tool, how much time are they spent editing it, and if there are errors, where are they coming out at? I want to know which sections. Is it in the drug history? Is it in the plan? Is it investigation? Is it in the patient details? And actually, when they do occur, where are the error caused by? Is it audio? Is it my LLMs hallucinating? Is it the prompts that needs improving? Or, and last but not least, the significance of this. At what point do I need to act on various sections for me to do something sufficiently to support them? Last but not least, I think just to summarize where I am with this, let me show if you move to the last slide, please. I think we at CLEARnotes really do spend a lot of time trying to understand how to validate and assure our quality of our outputs. The current ways of doing this really isn't quite enough because it doesn't quite reflect the complexity of this newer technology. And this really risks everything we've talked about, from the fact that our colleagues do not trust our AI tool, they're all slightly disillusioned with this new piece of technology, and all the benefits of AI that we all know can be achieved just goes completely unrealized. CLEARvalidate is our approach to breaking this very interesting, fascinating, complex problem down. We've tested, we've validated it against a real world use, and actually we've found that actually if we can do this well, we can support the users doing this better with their new AI scribe colleagues, and we can actually support the system and understanding where the risks are and how to mitigate them. But hopefully that's my end. Yeah.
Thank you very much. So thank you to all of our speakers. They were sort of really great insights into the importance of quality and safety when rolling out our AVT solutions. I'm very mindful of time. We have 1 minute left in our time, but let's open up the conversation and ask if anybody in the audience has any questions. We've got one in the chat here from Alex, who says, I'm interested in the evaluation plan in terms of differentiating technical changes from implementation effects, including team dynamics and clinical work/routine. Do you want to expand on that a bit, Alex, in terms of where it is that you work and what sort of angle you want the answer for this to come from?
Thank you so much for that. Yes, I work in evaluation, so I'm just trying to get a little bit more insights into how to differentiate this technical compliance, if you like, compliance revision from implementation effects, how the team dynamics change as they use these technologies. Just thinking about when the clinical teams use these technologies, they also feed into the technical changes or the hallucinations or the different errors that they see. So just trying to get a bit of insights into that. Thank you.
Yeah, no, that's a great question. Thank you. So in terms of the evaluation, we have evaluated this in various different ways. We've evaluated the outputs themselves, but we've also evaluated how our clinicians feel about using this technology as well. And some of that has resulted in clinicians saying that they feel less tired at the end of their clinics. But in terms of the outputs themselves, what I was talking about in my talk with regards to that continuous iterative process and the clinicians really being involved in that change and involved in that continuous improvement is really key. And that's why engagement from the clinicians is really, really important. But I think in each trust, it's really important to make sure that you have your own evaluation metrics as well from internally. Ken, I don't know if you want to sort of weigh in on this a little bit as well.
Yeah, no, it's a great question. I think you've answered it pretty succinctly. I think it's complex, which is why there's no one approach to evaluating it. You do need a wholesome, comprehensive view from the very technical side of things, backed up by some real human evaluation. So think of it as if you've got a new member of your team that's come to join your team, how would you evaluate them and how would you bring them into service? It's never going to be with one single number.
Yeah. Great question, thank you. We've probably got time for another 1 or 2 questions if anybody else has anything they would like to ask our wonderful panel of speakers. No, lovely. Well then, finally then, all we've got left to say is that we have our 3rd and final webinar as part of this series, which will explore scaling pilot projects to wider adoption, and that will be taking place this Friday, the 14th. And details and registration links will be sent to you if you'd like to join us. So do let us know. It's been great to see you all here today. So thank you very much, and thank you very much to our lovely speakers as well.